Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. Today's episode features Dr. Catherine Coombs from UCI Health and Dr. Toby Eyre from the University of Oxford. They will be discussing their choices of several notable studies presented at the recent EHA 2023 Congress on the use of BTK inhibitors in CLL and the associated potential clinical implications. This episode is part of a larger educational program titled Targeted Therapeutics in CLL and MCL, Applying Emerging BTK Inhibitor Therapy Data to Practice. For more information on the experts, along with a link to the complete program, including a downloadable slide set and expert commentaries, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Welcome to the 2023 Global Conference coverage updates on BTK inhibitors in CLL and mantle cell lymphoma. My name is Dr. Toby Eyre. I'm a consultant hematologist in Oxford in the UK, and I'm delighted to be joined by the Associate Clinical Professor Catherine Coombs, who works in UIC Health in California. Welcome, Catherine.
Hi, I'm Dr. Callie Coombs at UCI Health.
We're very grateful for Clinical Care Options to be facilitating this podcast. So we've had a very busy summer of data that's come out from ASCO, ICML, and also EHA. And to kick things off, I'm going to talk about chronic lymphocytic leukemia with Dr. Coombs. Callie, we had the first presentation looking at the CLL-12 study, which is the long-term readout of a randomized clinical trial taking asymptomatic treatment-naive early-stage CLL and randomizing between ibrutinib and placebo. We've seen the final results of this study. What did you make of it?
I think there's a lot to unpack from this trial. So a few things to keep in mind is that this trial began probably around 10 years ago. And so it was designed to see if there's a benefit to early intervention with ibrutinib. The primary endpoint of the study was EFS, and that had been previously demonstrated as superior for ibrutinib compared to placebo. But with this longer-term assessment, we're able to get a closer look into some other secondary measures, outcomes, including overall survival, which is obviously the most important thing when thinking about asymptomatic patients. The population that they accrued, they underwent a risk assessment using the German CLL study group score, which takes into account a number of clinical laboratory features. Only the low-risk patients were randomized all to receive just watch and wait. And so they were not part of the randomized cohort receiving either ibrutinib or placebo. A high amount of patients using this German score were anything but low risk. And so they fell into this increased risk cohort where half of them received ibrutinib at the standard dose of 420 daily versus the other half receiving placebo. And so I think it's just something to keep in mind. More than half of patients fall into this increased risk group from this study score. It's about 2/3 of the group. So when we take a look at the follow-up data, I think the really interesting things to unpack are that, number one, somewhat as expected, there was no overall survival difference between patients receiving ibrutinib or placebo. However, there was a difference in time to next treatment, which I would say is not unexpected, given that the patients on ibrutinib likely attained a therapeutic benefit from their CLL and so did not need another treatment for longer compared to the placebo. However, when we look at patients in the placebo arm, over the study follow-up period, only about half of them ended up discontinuing the placebo for the reason of progressive disease. Once again, stressing the point that perhaps a good amount of not so high-risk patients were included in this trial. Regarding the reason for discontinuation for the rest of those individuals, ultimately 80% of the placebo arm discontinued, but about 30% discontinued due to adverse events. Now, when we look at the ibrutinib randomized patients, around 70% discontinued due to adverse events. And the toxicity I think is one of the most interesting head-to-head comparisons we're going to see in any CLL trial, because it gives us a look into the natural history of watch and wait CLL patients. The amount of AEs that occur were actually pretty similar between ibrutinib and placebo when looking at just any grade events. However, when dialing into the AEs of clinical interest, of course, we did see a higher incidence of the classic ibrutinib side effects in patients receiving that drug, including bleeding and cardiac arrhythmias and hypertension. My take on the study is that it's definitely interesting findings, but not practice changing, in my opinion. At this time, I think the right answer, even for our highest risk CLL patients, if there's no indication for therapy, remains to be watch and wait, unless there's a clinical trial. And so I do think this doesn't close the book on whether early intervention with novel agents is needed. In the US, we have the SWOG trial. It's called the EVOLVE study, looking at early intervention venetoclax and obinutuzumab, which I think perhaps is a more attractive therapy to give watch and wait patients, given that it's time limited. The other advantage of that study is it focuses on a bit higher risk subgroup. It uses the CLL IPI score, so patients have to be either high risk or very high risk or have complex karyotype. And so instead of being about 2/3 of patients that walk in the door, it ends up being a little closer to only 1/3. And so hopefully of patients randomized, we'll see a higher proportion of patients in the watch and wait group progressing and needing therapy, as opposed to this group where only half of the patients in the placebo arm ultimately progressed, suggesting that perhaps we were over-treating a good amount of patients with ibrutinib on the experimental arm that may not have actually needed it for some time.
Great. Thank you, Callie. It was really interesting. And thanks for an excellent summary. I agree. It's a very interesting kind of concept, potentially moving to fixed duration therapy, and obviously working out how high your genomic risk is obviously challenging. Knowing how large or small to make that intervention group in terms of its ultimate impact in terms of the watch and wait field, I think is clearly a challenge. I was very struck by the number of adverse events that occurred in the placebo arm. I think it really speaks to both the fact that older patients with CLL do get adverse events, but also to some of our reporting procedures and the fact that we report a lot of low-grade adverse events, which may or may not be clinically relevant. So it certainly makes me wonder about not over-interpreting low rates of adverse events in clinical trials in CLL, for example, with patients on BTK inhibitor monotherapy, where we've seen fairly low rates of adverse events, for example, atrial fibrillation with acalabrutinib or zanubrutinib. You actually see low rates of AF, for example, in the placebo arm in this study. So it just food for thought, certainly. So we've got now 3 abstracts looking at frontline BTK inhibitor use, all very interesting and slightly different in their own way. We'll kick off with the SEQUOIA trial. So this was a longer-term follow-up of the pivotal frontline randomized study of zanubrutinib monotherapy given to progressional toxicity versus bendamustine rituximab, so fixed-duration immunochemotherapy. We've seen the readout of this previously, and it's been published in Lancet Oncology. But Callie, we saw a longer follow-up here with this study. What did you make of the results?
Yeah, so I certainly was impressed with the earlier results of SEQUOIA, but the big criticism is we would like longer term follow-up, which of course is always true. And so I was happy to see a bit of a longer data cut at the summer congresses on SEQUOIA. And the progression-free survival has now been reported out to 42 months with a median follow-up of 43.7 months. And the key findings are, of course, to no one's surprise, zanubrutinib continues to outperform bendamustine and rituximab. So BR reached its median PFS around 42 months, which is not unexpected. But zanubrutinib at that 42-month mark for the overall study population, 82% of CLL patients are still progression-free and alive, which is phenomenal. The study also had a separate arm where patients with 17p were funneled, given that it would not have been ethical to randomize them to bendamustine. And I was very pleased to see all well in patients with 17p. It was like 110 patients. And so the PFS at that 42-month mark was 79%, also quite excellent. We got to look at the toxicities as well. And so no big surprises. This still compares quite favorably to what we've seen with some of the earlier BTK inhibitors, specifically ibrutinib. The hypertension is 17.5% for the Xanu-treated patients when looking at the large randomized portion of the study. And so that does suggest to me that perhaps hypertension is something you do need to be on the lookout for with Xanu, but I think the cardiac safety is quite favorable. Longer-term follow-up and very good performance in the long term.
A very nice treatment option for patients, of course. So certainly interesting to pick apart some of the potential differences, maybe look at some of the reasons why you may or may not choose which of the two second-generation BTK inhibitors, which of course is a podcast in itself. It's interesting that the benefit now looks like it's in both the mutated and the unmutated patients in this study as well, which is another interesting and important finding. Excellent. So that's BTK inhibitor as monotherapy, but of course, lots of development in the field looking at fixed duration therapy as well. And we saw longer term follow-up of the CAPTIVATE study. CAPTIVATE study had different arms in it. One had an MRD-driven cohort, and then there was a fixed duration cohort. Callie, this is the 4-year update from this study. I wonder what you made of this data.
Yeah, so we've been seeing updates on CAPTIVATE, I'd say probably at most of the recurrent congresses. And so it's been very interesting to see how these patients are doing over time, especially with respect to their outcomes following completion of the planned treatment period. And so I would say my takeaways from what we saw at the summer European congresses are excellent, but many of them appear sustained over time. But we are starting to see a bit of separation between the entire group of patients and patients with the highest risk markers. The one that appears to have the highest rate of progression over now this 4-year period is patients with del17P and or TP53 mutations. And so you can see them fall off quite a bit with respect to progression. That being said, is the majority are still progression-free. And so we have not reached a median progression-free survival at the 4-year mark, which is great. But it does look like the most progression events are in this highest risk group of patients, which is honestly not unexpected. These are the group of patients that some may even advocate for only doing a continuous therapy and have hesitation to do anything time-limited because of what we have seen with other time-limited approaches, such as venetoclax, obinutuzumab, and then certainly back in the chemoimmunotherapy era, these patients performed quite poorly following completion of therapy, or even some progress while on therapy. I'm also struck by how well the unmutated IGHV patients did. Their progression-free survival tracks almost along with the entire cohort. And so there may be a few more relapse events among that group, but they are doing quite well with this longer-term follow-up. And then we're seeing just phenomenal overall survival. And so I think there is a big contrast between this CAPTIVATE cohort and the GLOW cohort of patients. And so CAPTIVATE enrolled these younger, fit CLL patients, whereas GLOW focused in more on the older, unfit subgroup of patients where perhaps the outcomes aren't quite as good as what we saw with CAPTIVATE. The other key difference between GLOW and CAPTIVATE, and of course, the other thing is these studies have different amounts of follow-up time, but on this abstract, we saw that there now is a correlation, a pretty convincing correlation between progression-free survival and attainment of undetectable MRD. And so that was not seen with GLOW, but GLOW's follow-up is a bit more immature, and perhaps with the older unfit patient population, there's more toxicities, et cetera. And so any difference may be attenuated, but that one needs longer follow-up. But now, at least with CAPTIVATE, with the landmark PFS rates at that 4-year mark, we're seeing a significant benefit. About 90% are progression-free and alive at the 4-year mark if they become undetectable MRD, compared to 66% for the detectable MRD patient. A good update. It's interestingly one of the very few drug combos in this case that was approved in Europe, but not approved in the US. So it's not something that I've been using, this regimen, with any frequency, given that it's not technically FDA approved. I'd be interested for you, given that it is approved where you are, what scenarios that you might use this combination and any other thoughts on the data.
Yeah, thanks, Callie. I think it's very important to see this longer-term data from this cohort. As you state, I think the toxicity profile looks very different according to the different age groups. My personal opinion is that this is the age group, the younger, fitter patients, that I think I would feel comfortable delivering this therapy in. I have some personal concerns about using the combination in older, more frail patients with comorbidities. I have to say, I was a little bit disappointed with some of the progression events that we're starting to see in the TP53 mutated patients, but particularly perhaps is the case that 15 months of therapy, 12 months of combination therapy is not quite long enough in this study, because we've seen studies with doublets that are delivered slightly longer therapy, academic studies that are MRD driven, for example, in terms of the stopping rules that showed the P53 deleted patients doing a fair bit better, the MD Anderson study being a good example. Interesting, and the debate will rage on as to how you best treat those TP53 mutated patients, fixed duration versus continuous therapy. Of course, one important thing is the PFS events don't necessarily equate to drug class resistance, and we have seen a bit of retreatment data with ibrutinib now. I think 19 patients from CAPTIVATE showing that nearly all respond to re-exposure to therapy, which I think conceptually is clearly a very important thing. Yes, we have increasing number of options, and of course I would throw the all oral fixed duration therapy option into the mix, which of course this is the unique aspect to this combination. Younger, fitter patients, perhaps with unmutated disease, I think I would discuss this regime with. But of course, different people have different perspectives on this. That's the group where I'd consider using it.
I think the glass half empty view is that the TP53 17p patients didn't do well, but I still think there is a real benefit for these younger patients to have time off therapy. But I think the missing piece of data is how long they respond to re-challenge. And so in theory, they shouldn't be resistant. But I think the first line is the one chance that these patients are going to get any treatment-free remission. And so I think if they have good and sustained responses to re-challenge of ibrutinib or even I plus V together, it may still be a win in my mind. I think that the follow-up is just immature with respect to retreatment. I think time will tell on that one.
Yeah, and of course, we've only got 27 patients out of 159 that have a TP53 mutational deletion. So the retreatment data for those patients is going to be pretty limited. But I agree, it would be a very conceptually important thing to look at moving forward. Excellent, very interesting study. I'm sure we'll continue to follow it over time. And then we saw one final abstract looking at time-limited therapy, which I think is important to touch on, which was looking at the combination of acalabrutinib plus obinutuzumab, so a type 2 glycoengineered CD20 antibody we've been used to using in CLL now, alongside the second-generation BTK inhibitor acalabrutinib. This therapy is approved as continuous therapy, but of course, fixed duration therapy has its potential benefits, as we've already discussed. So, Callie, we saw a smaller sort of almost pilot study, a conceptual study looking at the combination, but given as fixed duration. I wonder what you made of that data.
I actually was excited to see this trial. I think BTK inhibitors, maybe it was somewhat of an injustice to their development that they were never studied as time-limited options. And now that we have obinutuzumab that is quite effective an antibody. Often we see patients get to undetectable MRD when it's paired with BTKIs, not that frequently, but sometimes. I think this is an opportunity to see if we can use these combinations to get patients to deep enough remissions to have time off therapy. I wouldn't say it's a practice-changing study. It was only 20 patients, but I think very interesting conceptually, and we're going to need more follow-up on this one. But the idea is that 20 patients needing therapy by IWCLL criteria got a 3-cycle cala lead-in, followed by obinutuzumab monthly times 6. And then they could actually get another 6 doses of obin if they had not yet attained CR by cycle 8. And then in total, they got 24 cycles of therapy. The primary outcome was to actually look at how many were still in remission 6 months after completing 24 cycles of therapy, which is a low bar, but obviously, we'll want to see what happens with respect to a lot of the other secondary outcomes. So the patients, only one appears to have had any reasonable time off treatment. And so we do need longer term follow-up on this one to see what happens in these treatment-free intervals. But the PFS and OS look excellent. There was one death on the study due to presumed bacterial pneumonia, but otherwise everyone else is alive and progression-free. But they are seeing really high rates of CR. And so whether that's just the 6 cycles of OBIN, or perhaps a few of them opted in for those additional 6 cycles to deepen responses, that wasn't totally clear to me from the poster. But they're also seeing quite a significant debulking of the amount of CLL in the marrow. So only 6 patients have now been evaluable at that 2-year mark, but slightly over half of them were in CR, which is more than we would expect with a 2-year course of just a BTK inhibitor.
Yeah, thank you. I think it's conceptually certainly a very interesting study. We know that obinutuzumab induces MRD negativity rates, obviously historically being combined with chemotherapy and venetoclax in terms of its approval, but certainly with acalabrutinib, it does seem to be an attractive combination. Yeah, be interesting to see, as you say, the long-term follow-up of this study.
I think another aspect of this study that I wonder if I'll indirectly apply to some of my patients is acala plus obin does have FDA approval in the US as frontline therapy, but some patients end up coming off due to intolerance. I would say acala intolerance is a lot less frequent than ibrutinib intolerance, but I think if these patients do well and I end up with a patient with acala intolerance, perhaps this could give me a bit more confidence in how long of a remission such a patient may have in the event of that happening.
We've seen frontline BTK inhibitors being increasingly used in the frontline setting. And of course, this is not a curative therapy. Patients can stop because of intolerance or progression. And although venetoclax is a great treatment option, there's also the need for increasing options following covalent BTK inhibitors. And pirtobrutinib is a drug that's been in development over recent years. Callie, I know yourself and myself have had clinical experience of this agent in the BRUIN clinical trial, where we've seen very high response rates in patients who have been treated with the agent post-covalent BTK inhibitor. And there was some data this summer looking at the genomic analysis of patients who have progressed on pirtobrutinib. Some quite interesting findings. Callie, what were your thoughts about this?
Yeah, Jennifer Brown presented this genomic study from the patients who had progressed on BRUIN. And so this adds to the existing literature on pirto progressions. A smaller experience was published out of Omar Abdelwahab's lab from Sloan Kettering. This analysis actually had 49 patients who had progressive disease with available longitudinal samples, where they performed NGS on paired baseline and progression samples from these patients using a targeted NGS panel that included 74 genes. I'd like to just emphasize is that at baseline, these patients had significant pretreatment similar to the overall cohort of 4 median prior lines of therapy, and most of them had prior ibrutinib. So that was 88% for the whole cohort, and then 90% of the ones with progressive disease. Only 20% had prior acala, and then only 2%, or actually one patient, given that this was 49 samples, had prior zanu. But patients also, almost all of them had prior chemo, anti-CD20, and then about 45% had prior BCL2 inhibitor. But these patients that had progressed, there was a similar response rate among patients, 80%, which is what we've seen with the longer-term follow-up of BRUIN. At baseline, around half of this cohort had BTK mutations, which most commonly were the C481S mutation. A smaller amount of patients had other C481 mutations present. And so then when we look at what mutations were then subsequently acquired, and so mutations that were not present at the level of detection pre-treatment, but then emerged over time, 55% of individuals had the emergence of new BTK mutations. And so the most common was this gatekeeper T474 mutation, followed by what's called the kinase dead or kinase impaired mutation L528, which occurred in 11% of patients. I think the kinetics were interesting. And so they looked at the variant low frequency of mutations over time. And so what they saw is that almost all patients had a significant decline in their C481 clone that was either less prevalent or had just been completely cleared upon progression on pirto. but these new mutations emerged. However, that being said, about 29% of the cohort had no mutations that had emerged on progression, suggesting that there are likely alternate mechanisms of resistance to pirtobrutinib that have yet to be determined, whether that is related to expression or other larger scale changes such as cytogenetic, et cetera, is yet to be determined. I think the good news is that patients who did have emergence of these mutations did still respond to pirto. And when they went back and looked at below the level of detection, some of these patients, 24% specifically, had some of these supposed pirto resistance mutations pre-existing at baseline at low VAFs on the order of 1 to 2%, including patients who had been treated with ibrutinib, acala, et cetera. But fortunately, these patients did still respond to pirto, and having these low variant low frequency resistance mutations does not preclude the response of pirto, and they had a median time on treatment of almost a year.
Great, thank you. That's a great summary, Callie. Interesting data. I'm sure we'll see more of this as more patients progress on the study and give us a better feel for things. I'm intrigued by the fact that the CYS481 clones declined. And I suppose there's this open question about whether you can re-expose somebody to a covalent BTK inhibitor at progression. Could be an intriguing concept to explore in clinical studies.
I would love to see that.
I think it'd be very interesting, won't it? Thank you, Callie, for your insights. Really interesting data this summer at the congresses, looking at a variety of different BTK inhibitors. Thank you for your interest in listening, and I hope you enjoyed the podcast.
Thank you very much, Dr. Coombs and Dr. Eyre, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Targeted Therapeutics in CLL and MCL, applying emerging BTK inhibitor therapy data to practice, and to access additional resources associated with this program from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.